Hello, my name is Jenny Pagel-Guile. I am the Executive Director, and on behalf of the National Pancreas Foundation, thank you for viewing this webinar. You are part of our mission, and as we focus on supporting the education of our care providers, patients, and our medical community. We also want to provide additional information, so you are able to follow us on Facebook. We have a new Facebook page. Make sure that you can follow us for all the up-to-date information and upcoming events that we have in your community. And we are also on a variety of other social media platforms for you to follow. In addition to your participation in this webinar, we are always looking for volunteers. So if you would like to be a presenter of a webinar and have a subject that you are interested in presenting on, or if there are events in your community, such as Pancreas Bowl, we have galas, we have advocacy efforts, and a variety of opportunities to engage with the National Pancreas Foundation. And we look forward to seeing you soon. Today's webinar, The Nutritional Management of Pediatric Pancreatitis, is presented by Dr. Elissa Downs. She is a gastroenterologist who cares for pediatric patients in need of liver and gastrointestinal care, which includes children with cystic fibrosis, epidermolysis bullosa. Her clinical interests include acute pancreatitis, pancreatic insufficiency, chronic constipation, eosinophilic esophagitis, public health, and nutrition. In addition, Dr. Downs is an assistant professor in the Department of Pediatrics at the University of Minnesota Medical School.
Thank you, Jenny, for that kind introduction, and thank you to the National Pancreas Foundation for allowing me to speak on the nutritional management of pediatric pancreatitis. I'll start by giving you a quick overview of our talk. We'll first review fluids and nutrition strategies in the initial phase of acute pancreatitis. Next, we'll review long-term nutritional management and monitoring. And lastly, we'll address some of the psychosocial aspects of pancreatitis nutritional management. In the initial phase of an acute pancreatitis episode, fluid resuscitation is critical. Consider an initial bolus with normal saline or lactated ringers of 10 to 20 milliliters per kilogram, depending on hemodynamics. Then over the next 24 to 48 hours, administer IV fluids at a rate of 1.5 to 2 times maintenance rate. In pediatric studies, this level of fluid resuscitation in the first 24 hours was safe and well tolerated with D5 normal saline. Lactated ringers has been associated with shorter length of stay and overall cost of stay, but no difference was seen in some pediatric studies regarding the presence of SIRS, organ dysfunction, or mortality. So either fluids could be considered. If children are not otherwise tolerating oral or enteral intake, consider additional D5 in the fluids to prevent catabolism and hypoglycemia. Follow the BUN, hematocrit, and urine output as markers of sufficient fluid resuscitation. However, patients will also need to be monitored for fluid overload or other complications. The recent waterfall study in adults showed that aggressive fluids of 3 milliliters per kilogram per hour led to more rates of fluid overload, organ failure, local complications, and did not lead to a lower risk of moderate or severe disease. Within the first 48 hours, oral or enteral nutrition should be initiated. This reduces length of stay and rates of organ dysfunction, and as it does not affect readmission rates or lipase values. Children can be advanced to a regular diet as long as it is tolerated and not leading to further pain. In one pediatric study, children consuming a higher fat diet of greater than 1 gram per kilogram actually had less pain. If not tolerating oral intake, an NG can be placed with provision of standard formula. If children are failing an NG, then an NJ could be considered. And then even if needing to transition to parenteral nutrition, enteral nutrition to the point tolerated should be included to improve gut health and decrease any potential gut translocation. There are a few indications for parenteral nutrition, including ileus, fistulae, or prolonged expected NPO status. One potential indication for NPO status includes acute pancreatitis due to hypertriglyceridemia until triglyceride values fall below 500 milligrams per deciliter before advancing a diet with added fish oil or fenofibrate. After the initial attack of pancreatitis, or for those with chronic pancreatitis, what does long-term nutrition look like? No firm guidance has been established, and the ideal macronutrient content of intake has not been well studied. However, general guidelines have been laid out for both children and adults, but plans should be individualized. A low-fat diet has been proposed in adult-based guidelines of chronic pancreatitis, as some studies suggest this can help with abdominal pain. For kids, this would be a target of less than 30% of their total intake from fat calories, but may not be needed in all situations. Even without EPI or exocrine pancreatic insufficiency, fat-soluble vitamin deficiencies and mineral deficiencies are common, which may lead to low bone mineral density, among other complications. Poor growth can be common and is multifactorial, with 1, some element of increased resting energy expenditure, 2, abdominal pain, early satiety, or depression that may make it hard to eat, and 3, malabsorption in the presence of EPI. Diabetes will require additional diet modifications with need for carb control or carb counting and insulin coverage. Diabetes can further lead to gastroparesis and early satiety. An overall generally healthy diet is encouraged with adequate protein and fiber. Spicy foods and greasy foods may lead to worse symptoms, as well as tomato sauces, citrus fruit, and caffeine, among others. Pain can be very common during or after eating. Food journaling may help identify triggers, or one can limit the more common food and beverage triggers. Smaller, more frequent meals may be better tolerated. Intake that is lower in fat and or fiber will empty from the stomach more quickly. Liquid intake will also empty more quickly, so nutritional supplements can be added if children are not eating well. Additionally, if pain while eating, review enzyme dosing, consider additional antacid therapy, ensure children are not experiencing constipation, and discuss other possible strategies. What should we consider monitoring long-term to assess status after acute pancreatitis or with chronic pancreatitis? Proxy measures of exocrine status can include absorption studies such as fat-soluble vitamins and essential fatty acids. It should also include assessment of growth parameters with height and weight. Less well-studied parameters include mid-upper arm circumference, triceps skin folds, hand grip, or bioelectrical impedance. GI symptoms should also be tracked through different methods, such as Bristol stool chart, patient-reported outcome measures, or things like EPI symptom checkers. Longitudinal tracking for the development of EPI, most clinically practical, would be through elastase, even with some of its drawbacks. Developing diabetes should also be carefully assessed, and we should consider repeat imaging over time to follow for changes associated with the transition to chronic pancreatitis. How often should we measure, though? For now, that's unclear, but we do have recent guidance from several position papers, including our Pediatric GI Society. We recommend following anthropometrics every 3 to 6 months. If treating fat-soluble vitamin deficiencies, we recommend following repeat levels after 3 months, and GI symptoms should be assessed at every visit. At least every 12 months, but perhaps sometimes on the order of every 6 months, follow-up vitamin and fatty acid levels should be attained. If they do not yet have EPI, a repeat elastase or other measures of pancreatic function should be obtained. They should also be screened for the development of diabetes with referral to endocrinology as appropriate for follow-up testing. We can also consider assessment of bone mineral density. Let's review a few specific tests for exocrine pancreatic insufficiency. First, we'll review some of the direct tests to assess pancreatic function. The drilling test with tubes inserted to collect fluid after stimulation is invasive, technically difficult, and impractical, but it is our gold standard. A newer method for direct testing is via sedated endoscopic collection of duodenal fluid after stimulation, or an endoscopic pancreatic function test. It does require fasting and discontinuation of pancreatic enzyme replacement therapy to complete the test. Protocols do vary from institution to institution, but it is felt to be a comparable alternative to traditional tube tests in less time, and it's overall safe. Secretin-stimulated MRI can also be considered with intestinal filling assessed after administration of secretin, but this may also require sedation depending on age, and there are many different protocols and methods currently used. Indirect testing will generally be the most clinically applicable, even with known drawbacks that we will discuss. An assessment of fecal fat or a coefficient of fat absorption is a method to quantify fat absorption as a percentage of how much ingested fat is excreted in stool. This is a cumbersome test, as traditionally stool collection is done over 72 hours. Our most widely used test, the fecal elastase 1, or just simply elastase, can be measured very early on in life on a spot stool sample by the ELISA assay for human elastase. It has several factors in its favor, including degradation resistance, stability, targeting of human elastase, and overall high sensitivity and specificity, but there are a few major factors to consider when analyzing the results. We can see a false positive diagnosis in watery stool as this dilutes out the elastase, and it is not able to detect isolated enzyme deficiencies. Other testing as listed is not commonly used given associated costs and overall lower sensitivity and specificity. Once EPI is diagnosed, we start additional pancreatic enzyme replacement therapy, or PERT, with every meal and snack. This is a great graphic of the currently available enteric-coated enzymes, as well as the newer immobilized lipase-only cartridge, Relisorb. Pancreatic enzymes are dosed in standard ways for oral intake, either by weight-based dosing or fat gram intake dosing. Weight-based dosing is most common, but there is a broad range of doses we can use from 500 to 2,500 lipase units per kilo per meal. We provide half doses for snack intake. If families are adept at assessing grams of fat to be consumed at a particular meal, fat intake-based dosing can be more precise. We do recommend staying below 10,000 lipase units per kilo per day, as historically high doses of enzymes led to a complication called fibrosing colonopathy. For those children on tube feeds, we have a few different strategies. Relisorb is the immobilized lipase-only cartridge that can be used in line with enteral feeds. The first generation cartridge could only be used with continuous feeds, but the second generation can be used with continuous or bolus feeds. One cartridge can be used to cover 500 milliliters of formula with a max of up to 6 cartridges per day. There are some limits on types of formula that can be compatible with a cartridge. For example, higher fiber formulas are not compatible. The smallest Pertzy capsules can be opened and 1 to 2 mixed with applesauce and then given through a larger bore gastrostomy tube prior to feeds. With this method, you would have to redose for longer feeds, as enzymes are still only active for approximately 45 minutes after being administered. Crushing the non-enteric-coated Viocase tablets and mixing into the tube feeds prior to administration is an older method and not FDA approved. Enzymes should be given before every meal and snack. Pure, simple carbohydrate intake may not need to be covered, but it's best to be in the habit of always covering. In addition, enzymes should be stored carefully to prevent inactivation. This includes a cool, dry area and a well-sealed container. What are some things to consider when enzymes don't seem like they're working? Question the child and their family on the timing of enzyme administration with eating. Are they doing this just before a meal, partway through a meal, or after a meal? How often are they taking their enzymes? Are there times that they forget? And how are they storing their enzymes? Are they being stored in the conditions we just reviewed? And then how long are children taking to eat? If this is longer than 45 minutes, we may need to divide and redose enzymes. Then consider if their current dose is within the range for their weight. Consider increasing the dose if children are losing weight or having cramping, bloating, or steatorrhea when they've been taking enzymes appropriately. One of the things we could also consider is an alternate enzyme therapy. As we reviewed, each has different sized microtablets or microbeads, but the Pertzy brand also does contain a bicarbonate buffer. And then review if they're having signs of reflux or gastritis. Antacid therapy may help with the pH release of the enzymes, similar to the bicarbonate buffer in Pertzy. And then at some point, we should be evaluating for comorbid conditions that can mimic enzyme inadequacy or cause decreased stimulation of the pancreas' natural output. Those can include things like celiac disease, other forms of enteritis, inflammatory bowel disease, other gut infections, thyroid dysfunction, diabetes and gastroparesis, lactose or other carbohydrate intolerance, or bacterial overgrowth. In the setting of EPI, specialty pancreatic multivitamins should be prescribed. These are water-soluble versions of the fat-soluble vitamins to optimize absorption. Some versions are more complete than others, but still do not contain iron. In the graphic on the left, you'll see an example of one of the formulations, which is from MVW Nutritionals. And in the chart on the right, you will see a head-to-head comparison of a few of the available fat-soluble vitamins on the market. While some children may do fine on a standard multivitamin, vitamin levels should be monitored more frequently. Multidisciplinary care is paramount to address the full spectrum of psychosocial aspects of pancreatitis. Education will be provided to the patient and their family from a variety of resources: their GI physician, registered dietitians working with the team with specialty in pancreatic disease, among others. Malnutrition significantly impacts outcomes, so efforts should be made to optimize this as much as possible. From a regional or national standpoint, providers and patients can receive education from their local MPF chapters, websites, or GI societies. Additional support and resources should come from counselors or therapists with specialty in chronic disease adjustment, given the impacts of pancreatitis on quality of life, as well as physical and mental components of well-being. More broadly, further support can come from patient support groups and foundations like the MPF, Rebecca's Wish, or Mission Cure. Lastly, it's important to make sure that children can experience the full breadth of normal life activities. Diet restrictions should be communicated with school and activities staff, as well as stressing the importance of taking enzymes right before every meal and snack, and storing enzymes appropriately as previously discussed. Your provider team is happy to serve as advocates in this, as involvement in school and activities will improve children's quality of life. Thank you so much for your attention.